Okay, could we welcome to the stage Dr. David Unwin, please?
Well, hello Manchester. Here I am. Isn't it wonderful not to be on a Zoom? That you're actually real. The only thing with Zoom is, I don't know whether you've seen, there's a special control, wrinkle control. So when I do Zoom, I turn the wrinkle control on maximum, and then my face, because I'm so old, my face just blurs. Because when they take out the wrinkles, there's not much left. So you're all looking at me thinking, oh, he's aged terribly. Anyway, so I am an older GP, clearly. I'm from Southport, not far away. We look after 9,500 patients. There are 9 GPs. And the story really is one where our practice has been totally transformed. And the next 90 minutes is about, I hope you're interested in how we've transformed our practice and our patients. And I'm trying to share with you what I've learned since 2013 and help you do the same, really. So my first question, I haven't got too many questions, but my first question is, we're all clinicians. How many of you in this room have met somebody who has made a difference by cutting sugar and starchy carbs in their diet? Just put your hand up, please, if you've met. Wow. So it's easily 3/4 of us. Second question. I'm absolutely fascinated by drug-free remission of type 2 diabetes because it's such a brilliant thing for patients. It transforms them. And I often say it makes you feel like a magician if you see it. It's so brilliant how they change. How many of you clinicians in this room have met somebody who's achieved drug-free type 2 diabetes remission? Could you put your hand up if... Good. Quite a few of you. So you know how amazing that is. I should define drug-free type 2 diabetes remission. This is somebody who is on your diabetic register, and they've got to be drug-free, that is drugs for type 2 diabetes, for 3 months, and they have to have a hemoglobin A1C of less than 48. So much of this talk is about drug-free type 2 diabetes remission. And obviously from the title there, 100 and not out, we've now, last Thursday, I met my 105th patient, 105 patients who've achieved drug-free type 2 diabetes remission in the NHS in Southport. And they're not all my cases. The practice nurses are doing this, the other partners, and the GP registrars are all having successes in our practice now in 10-minute appointments. And I know there are GPs and practice nurses and dietitians and anybody else I've forgotten achieving this all over the country. It's so terribly exciting. Before we get on to a little video I've brought, conflicts of interests. Why should you listen to me? Perhaps I'm paid to say this. Am I paid? Where's the organizer? I don't think I am. No money was ever mentioned. But if you did pay me, I donate it to the PHC. This is a British charity. There's a table by the PHC over there. It's a British charity trying to get better public health information to healthcare professionals and to patients. So I donate anything I'm paid to that. I never accept money. Conflicts of interest. Oh, I'm hopelessly biased. Hopelessly biased because I've been low carb for 9 years. So I'm in nutritional ketosis. I'm in ketosis. I've run 5 miles this morning. I haven't eaten anything yet today, and I'm still standing. So that's interesting. So I am biased because my own health has improved so much. I just did it at the beginning alongside the very first cohort of patients. I didn't particularly believe in it, but I thought I'll try it with my patients back in 2013. And as it were, experiencing or seeing is believing, and it's changed my life so much. I'd like now to hear from one of my wonderful patients. This is Roy, you're going to hear, and he did a professional video along the lines of what would you like healthcare professionals to understand what it's like as a patient that goes low carb. And so, over to Roy. I hope. Oh, he's coming. Here he is.
30 years younger. I used to have for breakfast usually cereal. Wrong cereals, probably, and a lot of it. I would have 3, perhaps 4 Weetabix or a big bowl of porridge or whatever. I think the significant thing that I've realised is I didn't need that. And I'd love other people to learn what I've learned. I never found the low-carb diet particularly difficult. I don't crave sausage rolls anymore. I don't need it and I don't want it. And what I have gained is such an advantage over eating sausage rolls. Being diagnosed with diabetes opened my eyes to my bad lifestyle. It's changed the way I look at life and how I am. It was a gift. It's a gift from above. It's a strange gift, but it's made huge differences to me as a person.
So that's Roy. I've got quite a few patients who've made videos because their life has changed so much, they suddenly want to change the world. I featured Roy because, as Roy says himself, he's an ordinary bloke. And your surgeries all have ordinary blokes in. And as Roy says himself, if I can do it, he's 73, then, well, who can't? Maybe all of us can do it. So well done, Roy. Let's press on now with the presentation. We're going to meet somebody else. This is Marcia. Marcia is not from the UK. She's actually from Brazil, so English isn't her first language. There we are. She's 52. She weighs nearly 100 kilos. She's been on a high dose of insulin since 2004. Her hemoglobin A1C at this point is 64. So that's a poor control of diabetes. And if you look at Marcia, life is hard. It's a struggle. You've all got patients like Marcia. They're heavy, they're inflamed, she walks with a stick, she's got chronic pain. Life is really hard, and she's only 52. And what's very interesting is, so I've been a GP in Southport in the same practice since 1986, a long time. When I joined as a young partner, we audited everybody with type 2 diabetes in the 9,500 patients. And guess what? There were only 57. That's all there was. There are now 500. This is a pandemic. Diabetes is a pandemic. All over the world. I go all over the world now talking about this, and whether I'm in Malaysia or Australia or America, the clinicians are telling me exactly the same. They can't cope with an absolute tidal wave of obesity, high blood pressure, fatty liver, and type 2 diabetes. And really, until 2012, I hadn't got a thought in my head what I was going to do to help people like Marcia. All I did was just prescribe more and more drugs. It's so depressing, isn't it? You've all done that. They come in, it's a disappointing result, you tell them off a bit, and then you add the next drug and the next drug, and then you add the drug that they need for the side effect of the other drug, etc. And it goes on, and it becomes unpleasant, becomes slightly, I found it made me anxious because I felt like I was a failure because I didn't really see people get any better, and I'd become a doctor to make a difference. And I wasn't making a difference. The drug budget was going up and up. But looking at the waiting room, I never saw really fit people. I never saw well people. So somehow we go from that in 2012 to 105 patients with remission of their, drug-free remission of their diabetes. So a massive change to our practice. So that's just the 8-fold increase in diabetes, and that's happened in all your practices, I'm sure it has. Anybody in one practice, the waiting room now looks quite different. There were hardly anybody at Norwood Avenue with obesity. That was rare. Diabetes, very few, and they were older. They were older, they were all over 60. We called it maturity onset diabetes in those days. Well, we don't now, because the youngest I've got is 10 years old. What is the future of that 10-year-old? What is his future? Shall we give him drugs? What shall we do? It's a terrible thing, and we must, all of us, we must do something. But the good news is we can do something. Oh, I've got the wrong slide. Here we are. One last little point before we go to the next slide. We know, look there at the hemoglobin A1C is 64. So for every year that you have a hemoglobin A1C of greater than 58, you're losing 100 days of life. So what's going to happen to the 10-year-old? If he has a high hemoglobin A1C, his life is shortening by the year. It takes about a third off your life. And that is the National Office of Statistics. So we shouldn't be relaxed about poor diabetic control, because it kills people. Kills them with cardiovascular disease. This is very serious. Right. So go back to Marcia. There we are. There she is now. So here's one I did earlier. All right. Totally unrecognizable. So Marcia now is off her insulin. She's lost loads of weight. She's exercising. She's so proud. She's been in the Daily Mail. She had a makeup job and everything for the Daily Mail. She is transformed, and she says coming off insulin was so amazing, not to be so heavy. She's not in pain. She keeps scrupulous records now, so she was disengaged at the beginning when I first met her, because she'd given up hope. She said, all I ever do is increase the insulin, and it makes me fatter. She knew that. She knew that. Now she's sharp as a tack. She had been, because English isn't her first language, people didn't realize how bright she was. They didn't realize she's a very intelligent woman, capable of change. And I looked after that lady for years and didn't save her. And it took me a few years to realize I could have a go trying help Marcia. The other thing is, so not only has she come off the insulin, but her blood pressure is now normal, and she was on a high dose of ramipril, probably amlodipine as well. She's off everything. She's not really a patient anymore. She's wanting to help other doctors like you make a difference. What a change, what a change. I've said that, so cases like Marcia, it says there's 101. There's, as I told you, it's now 105. Blink, and there's another. There'll be more when I get back next Monday. Some of you may wonder, well, perhaps he's a fraud. I'm sure some of you think I am a fraud. Perhaps I am. But is he doing this by prescribing loads of drugs? You may know that every GP in the country is being monitored by a wonderful website called Open Prescribing. So if you are a GP in the audience, or if you've got GPs in your practice, you can check on the GPs in your practice and find out what are they doing. If we look at Norwood Avenue, we're spending, it's about £60,000 per year, less than is average for the area in Southport. So we're not using drugs. We are the cheapest in RCGP. I would say, so since 2013, I've actually initiated drugs for diabetes perhaps on 10 occasions. 10. Now it was 10 a week before. That's such a change, and it's because I'm really interested in, why is this patient in front of me unwell? Why are they unwell, and can we do something about the real cause of their illness? And if you do that, you start saving the drug budget. If every GP in the country prescribed the same as we do at Norwood Avenue, you would save £277 million on the drug budget, because diabetes is just about our greatest expense. That's how serious the epidemic is. You met Roy already. So there's Roy. That's how he looked on the day he came to see me, although he didn't have a bow tie. But that's how he looked. And if you look on the right, there's his hemoglobin A1C chart. And he came in one afternoon to be told that he had type 2 diabetes. And you can see there the chart, his hemoglobin A1C was 51. And so for this afternoon, the question is, if you look at that graph, his hemoglobin A1C dropped very rapidly to, I think it was 38. and it's 38 now. He's maintained that improvement for 2 years. So there are two questions. Is what did I do in a 10-minute appointment to change Roy? And could you do that in a 10-minute appointment? And then the second question is, what have we done at Norwood Avenue to maintain Roy's position so that he is the man you saw on the video, not a yo-yo dieter? That's him now. So that's, again, what we're looking at. And we're going to have to look at the role of hope. The role of hope and psychology in clinical practice. So my wife is a consultant psychologist, and her entire life is spent on how do we motivate people to behave differently. That's what psychologists are experts in. And if you think of so many of the people you see, what you're struggling to do is get them to change behavior. You're struggling to get them to exercise more or eat less or whatever. So a knowledge of psychology could be so useful to you. And I'm hoping to give you just 5 minutes on behavior change shortly. It only takes 5 minutes to teach you everything I know, so it can't be much. So psychology, terribly important. The next thing is physiology. And I think rather than telling people what to do, rather than telling our patients what to do like I'm a talking leaflet, I would be really happy if Marcia could understand the information I'm giving her. So she doesn't have to memorize the diet sheets that are on your table here. She understands the physiology of diabetes and can implement it herself, even though English is not her first language. So that'd be another good thing, wouldn't it? If I could help you to explain to your patients about diabetes so that they can understand what action they should take. But it's always important to begin with motivation. I think as a young doctor, I was in a hurry in 10 minutes to tell people what to do. So I would rush into, you need to do this, and you should do that, and you should do the other, before I'd ever really engaged in them as a human being and found out about their hopes and beliefs. That's why we need to start with psychology. So psychology is, from my point of view, such a useful tool about helping people change. And what I learned from my wife is there's two things really. All of us have hopes. You came today, I suppose, either hoping for a good lunch or hoping to learn something. All of you have hope. Hope to be a better clinician. Hope to be a better parent or a grandparent. Each of us have hopes. Also, each of us have fears. And if we weigh up the two, and they have done research into this, I think I used to use fear far too much. And I was shroud waving, you know, if you carry on like this, you'll end up with an amputation or it'll be leg ulcers and so on. People tend to disengage if we frighten them. And then you wonder why, you know, I had some cases and I wouldn't see them for 5 years. And then I'd say, why? And they'd say, well, you told me off. So why? They don't come to have us tell them off. So you can use fear or you can use hope. And what Jen has taught me is the hope is very powerful. It's very powerful. And if we can use it in a clinical scenario, it's great to have in your bag of tricks. Only how do you do it? A bit more on hope. Slightly more complex than that, because if you've got hope, if you have a goal, any goal at all, a goal, I think being a better parent is a common one, isn't it? Then you are motivated. So if you think about your goal, you start moving into the future a bit. So goals make you move positively into the future, whereas fear is a bit aversive and you just don't think about it. And I'm claiming it can be done briefly in a 10-minute appointment. So this is the 5 minutes. Let's see if I can do it in 5 minutes. So it's called GRIN, G-R-I-N. So it obviously stands for something. 4 steps. And this isn't my work, it's my wife's. So G stands for goals. And so can the clinician and the patient agree on a shared goal? Rather than me telling you, wouldn't it be great if we had a shared goal? So often I'm asking patients about their health and saying, in a year's time, if we could do something brilliant, what sort of goals have you got? What would you like to do that might improve your health, would be part of better health? I get told all sorts of things. I'd like to breathe better. I'd like to wear fashionable clothing. I'd like to do a 5K, all sorts of things. But the more detail the patient gives me about their goals, the more likely they are to pursue them. The more they think about their goals, imagine what their life would be if they could wear fashionable clothing. What sort of a difference would that make? So I'll illustrate this. People tell me all the time, I'd like to lose weight. That's a slightly empty goal. There's not much cognition behind it. There's not much thought. But if you say, what difference would weight loss make to your life, then it's real. Then they're describing their own life and it's personal. And I'm endlessly fascinated by people's real goals, because if I join in, they work with you. People are always saying, oh, my patients, Dr. Unwin, how do you do this? You're like a magician. No, I'm not at all. But I am very interested in people's goals, and it makes such a difference. And then the medicine you do is so personal and collaborative. It's really, I get paid for this, and it's good. Every clinic I'm seeing cheerful people, and I'm discussing how they're doing. So that's G. What difference might weight loss make to your life? Tell me, G. Toolkit. So the next one is R. The people we care for are not empty receptacles waiting for our genius to help them. They are clever people in their own right. Marcia, clever woman. People have resources, resilience, and experience. And if we can use that, well, we're adding value. So have you lost weight before? How did you do it? How did it feel? Who helped you? Is anybody else in the family interested in this? Might they come along with you? So resources, so important. Another one of my interests is palliative care. And I use this model in palliative care. And it's my opinion that resilience in palliative care is the most precious thing. Resilience in the clients and resilience in the family members, because they're going to suffer probably a great deal. Looking for resilience and celebrating resilience, far more important in my mind than drugs. So wonderful. So resilience and resources. There's a ruler there that stands for increments. Obviously, as a GP, I deal with a lot of teenagers. They're quite tricksy, aren't they? Teenagers, they're quite tricksy. But if you get their goals, that's really interesting. But there's a tendency for them to want to be an astronaut or want to be something unusual, but they've not actually thought about the small steps, the realistic small steps that lead towards their goal. And that can be so useful. I'll just illustrate this because we've got 90 minutes together, so I've got ages to chat on. So I had a teenage girl brought to me by her mother. Her mother was fed up with her, and she brought her in and said, well, I hope you can do something with her, Dr. Unwin, because I can't. I don't know what to do. She won't leave her bedroom. She's not going to school. I've done everything I can. Go on, tell him. And of course, the teenager is absolutely mute because she doesn't want to tell me how bad she is. So we send mother out of the room, and then she looks like, right, well, I'm not going to say a word. And we all know the thing to do with people who won't say a word is absolute silence, because they'll crack before I will. And it turned out her goal was so interesting because she got a great interest in marsupials. Isn't that amazing? Marsupials. And she'd quite like to study them. But that goal was a bit distant from I'm in my bedroom the whole time, isn't it? So I'm saying, well, that's brilliant. That's so exciting. Tell me a bit about marsupials. And she did. And she already knew a lot. And then I'm saying, so if I could ask your mum to be helpful in one way, what would you do? And she said, there's a magazine I'd really like Marsupials Weekly or something. Could you ask mum if I could have that? That's a small step, that's an increment. And what's so interesting is when her mother came in the room and I said, your daughter is intelligent, eloquent, and who knew about all this marsupial business? She was shocked. And she burst into tears. And she burst into tears because mothers love their daughters, they do. They're aggravated to bits. But she was just desperate. And when she saw her daughter in a new light, of course she'll buy the magazine, and of course. So that was a way of moving forwards, and the increment, so important. This is way, way beyond diabetes. It's useful in so many things. Right, so what does N stand for? Jen thinks that N is the most important thing. N stands for noticing. Noticing what works. And of course, if you think about it, feedback is absolutely key to behavior change, isn't it? So in a clinical scenario, you'd need to think, what feedback might patients need so they know they've done the right thing? So what would you measure? What would you do? Photographs are very good. So sometimes I get somebody, I say, right, well, we've done your goal. I understand your goal, weight loss. How about you take a secret photo of yourself today, along the lines of this could be the fattest you're ever going to be, and keep it, and only show me if we succeed. And that's, you'll see some of you may have read, I've done about 40 or 50 articles in the Daily Mail, and some of the before photos were these people who took a photo and then they cashed it in when they go, thank you, it's amazing. That's feedback, very powerful feedback. But there are many other forms of feedback to think about. It could be a waist circumference. It could be a hemoglobin A1C. It could be so many different things. So think about feedback and how patients would know they're doing well. So here's some feedback. This is another one of my patients, and there's two types of feedback there. One is his belt, and you can see where his belly used to be. That was a year ago. That's his belt that he's worn ever since, and that's where his belly was a year ago, and he's lost 40 kilos. There is his weight graph, and any of you who follow me on Twitter will know I often do graph of the week. So my patients love to be graph of the week, and they say, am I graph of the week? And many of them are. And the EMIS computer system that many of you are using is wonderful at generating graphs. It is so simple to do so that you can produce graphs at the touch of a button for your patients, and they know how is the liver function going, how is the weight going, how is my waist circumference. Because many people, it depends how we learn. Some of us are visual learners, and if you are, the feedback of a graph can be very powerful. So that's graphs. And that's an empty slide. Oh, we finished. We've done psychology. So now I want to talk about physiology. And for me, physiology is about explaining dietary principles in a way that my patients can understand and remember, so they don't need the leaflets because they remember. So I'm going to have a go at showing you how I help Roy. So this is it, type 2 diabetes. So I explain to patients that you have a hormone produced by the pancreas gland, and that hormone is vital to life, and it has a really important job to do. The hormone insulin has to get blood sugar down, because over time it's a high blood sugar that damages your large arteries to give heart attacks and strokes, and damages your small vessels like eyes and kidneys. So the pancreas is doing a vital job through insulin. Insulin pushes sugar out of the bloodstream where it's harmful and into muscles for energy. But what if you eat more Mars bars then you need to run around. What happens to the rest of that sugar? Questions are always more powerful than statements. So just think about it. Where does insulin put sugar? And here we have the answer. Insulin pushes sugar into cells. Muscle cells, certainly for energy. But if you continue to have more bread or sugar or whatever it is than you need, you're starting to put sugar into liver cells where it becomes a fat, triglyceride. There is another epidemic, non-alcoholic fatty liver disease. I'm sure you've heard of that. That is now a quarter of everybody you know. Now that's a pandemic. That's a quarter of everybody in the developed world has non-alcoholic fatty liver disease. When I read that, I didn't believe it, so I did an EMIS search on triglyceride levels and gamma GT liver function for everybody at Norwood Avenue. A third of all the tests are abnormal. I had no idea it was that bad. So the liver cells are filling with fat. The only thing liver cells can do with sugar, once your glycogen stores are full, is turn it into fat. So you get fatty liver. It's not the only place, though, that insulin's busy. Insulin's busy in your belly. That's why I used to have middle-aged spread, because I was a biscuit fiend and very stressful jobs. And, you know, I'll eat, particularly if I saw somebody, you know, a heart sink patient on the list, I'd be eating 3 or 4 biscuits. Some people were 6 biscuit people because they were so scary. And I just got into a habit of eating biscuits because I felt it gave me a little boost so I could face whoever it was. But the result, of course, was my belly got bigger and bigger. Because the insulin was pushing the sugar, it has to do this as an imperative. And here is one of my patients. And you see on the top graph is serum triglyceride between 2010 and 2021. And you'll see that she had a raised triglyceride there. And it's been in the normal range now. I suppose that's for 11 years. Look how the graph mirrors the hemoglobin A1C beneath it. She had very poor controlled diabetes back in 2010. She's had remission of diabetes ever since then, and the two graphs look almost exactly the same, and it's because triglyceride levels, sugar in your diet, and diabetes are all linked. A high blood glucose is linked to a high triglyceride level, and in fact, if you want to sort out a patient's triglyceride, nearly always a low-carb diet will do it. This is a slide from, some of you will have heard of Professor Roy Taylor, one of the world's greatest experts in type 2 diabetes. He's based in Newcastle, he's been on the television a great deal, and he also is working on remission of diabetes and published the DIRECT study, and this is the replacement shakes that maybe some of you are using now. So he points out that as you continue to have more sugar in your diet than you need, the liver fills with fat, as I've already explained. But here's the thing. A fatty liver interferes with the vital work of insulin itself. So that gradually you become insulin resistant and your insulin doesn't work properly. I think I'm defining diabetes, aren't I? Type 2 diabetes, your insulin no longer works properly. And unfortunately, as I continue to eat Mars bars, or biscuits or whatever it is, the pancreas fills with fat as well. And a fatty pancreas, the fat interferes with the beta cell function, so you can't produce insulin. And these are some of the very end stage type 2 diabetics who are needing insulin. They're insulin resistant, but they're even struggling to produce enough insulin. So you've got a double whammy there of diet leading to diabetes. So it's pretty obvious, though, if you could reduce carbohydrate intake, you'd reduce liver fat, you'd lose weight, and you'd reduce pancreatic fat, which would increase insulin sensitivity and secretion, reversing type 2 diabetes. Hooray! And this is what my patients are doing. This is what Roy Taylor's patients are doing. The important thing I'd say is there are different ways to achieve drug-free type 2 diabetes remission. There isn't one way to do it, there are several. There are so many sick people, there's enough, we don't need to fight over them, heavens. There's different ways to do this. Bariatric surgery does work very rapidly. There are pros and cons to it though. The shakes work really well, but there are pros and cons. Low carb works very well, but there are pros and cons. What we're trying to do is suit the approach to the person in front of us. Individualize it. And I think that's what we need to think about in the next decade if we're to make a difference. Because prescribing drugs is not going to save us from the diabetic epidemic. It's making no difference, really. And you wait till they're sick as well, it's far too late. So it becomes obvious about that sugar is a kind of metabolic poison. And if you have type 2 diabetes, you're struggling to metabolize sugar, so you ought to avoid sugar. And most of our patients have cottoned on to that already, haven't they? And they say, well, I've given up sugar in tea and coffee. And I saw a patient 2 weeks ago, an elderly person aged 77, and his hemoglobin A1C was, I think, 75, very poorly controlled diabetes. And he had polyuria as well, so he was weeing all the time, and that meant he was getting up in the night, and then he was exhausted. So I'm saying to him, well, where do you think the sugar has come from in your diet? And in fact, please remember that. Ask your clients, where do you think the sugar has come from in your diet? Because questions are more powerful than statements. Ask them, and you'll find stuff out. And this guy, he said, well, it's a mystery to me because I've been eating this special bread, and there it is. He brought me a photo. No added sugar. So he wasn't a foolish man, but he'd been eating this special bread because it said no added sugar. And he didn't know that starch is glucose molecules holding hands, that bread is low to sugar, that rice is low to sugar. So the poor guy had done his best, but he was actually on a very high-carb diet. Many older people are, because it's convenient. So he's making himself butties all day long, and breakfast cereals and so on. So he was having sugar with his sugar with his sugar, and he felt ill. There is the starch molecule. The very first patient I ever met with remission of type 2 diabetes came in to complain about me. And she was complaining because she said, Dr. Unwin, you've been giving me metformin for over 10 years. And by the way, it does give diarrhea. You never once, not once, did you mention that bread and breakfast cereals are sugar. You just gave me that drug and you never asked me. I'm wondering whether you've got O-level biology. And you know, she'd made a really good point because I never once had mentioned that bread was sugar and breakfast cereals were sugar and rice was sugar and potatoes were sugar. Not once. And she didn't like to tell me about the diarrhea because it was embarrassing. She found the low-carb diet online. There were 40,000 of them doing it and advising each other how to do it. And that's why nearly every person in this room has found somebody on low-carb. Hundreds of thousands of our patients are doing it. They don't all like to tell us. She'd done it secretly, but I knew she wasn't taking a metformin, and I'd actually invited her in for a telling off how wrong I was, because I got told off. But I learned really fast because she was a formidable woman. And I actually was honest, I had a lot to learn. That was 2012. So starch is glucose molecules holding hands. And all those foods are really sugar. So if you just think about your diet, you wake up and you think you're doing the right things, so you have cornflakes or you have bran flakes, and you have just one slice of wholemeal toast, and then you have a glass of fresh orange juice. You just had sugar with your sugar with your sugar. What are you going to have for lunch? Oh, I'll have a sandwich. Oh, more sugar. Second course, I'll have a packet of something. More sugar. What am I having for tea? Rice or pasta or chips. You just had sugar with your sugar with your sugar, and you have diabetes, so you can't metabolize sugar, and then you're wondering why you're ill. And if you look at NICE guidelines, they do actually say encourage high fiber, low glycemic index sources of carbohydrate in the diet. It's there in the NICE guidelines. Low glycemic index sources of carbohydrate. That's what we should be doing. And it works. And then hardly anybody would need drugs. So back in 2013, I become fascinated by the glycemic index, as in the NICE guidelines. I become a glycemic index bore of a huge magnitude. And in the end, the partners said, would I please stop talking about the glycemic index, because it's actually boring, and also they don't understand what I'm on about, although I seem very enthusiastic. It was Cotty Schultz, a lady partner, very plain-speaking woman. And she said, David, why don't you go away for a while and come back when you can explain the glycemic index to our patients? So I went away. I found an expert on the glycemic index called Jeffrey Leavesey, because I had an idea. The problem with the glycemic index and the glycemic load is it gives answers in grams of glucose. Our patients do not understand grams. They really don't. They don't know what 16 grams looks like. And they're not familiar with glucose either, because they don't cook with it. So we redid the maths on 800 foods in terms of teaspoons of sugar. A 4-gram teaspoon of sugar. So now I can tell you that 150 grams of boiled rice is approximately the same as 10 teaspoons of sugar. When people see that fact, they suddenly understand when I say, where did the sugar come from in your diet? Suddenly they know. Boiled potato, about 9 teaspoons of sugar for 150 grams of boiled potato. Chips, 7.5. Spaghetti, sweet corn. Even a single small slice of wholemeal bread is the same as 3 teaspoons of sugar. So maybe eat something else. And if you look at eggs, meat, fish, dairy products, they don't put up your blood sugar at all. So that's the basis of the low-carb diet. Why don't you eat something that isn't a metabolic poison? It's kind of logical, really. These teaspoons of sugar equivalent, here's another one about fruit and veg. There are, I think I've done 9 of these now. They're freely available. If you Google PHC, which is the charity, and sugar and Unwin, none of my work is copyrighted. And there are high-quality versions of these in 12 to 14 languages available on the PHC website. Yeah. So if you Google capitals PHC, the word sugar and Unwin, it'll take you straight to the PHC website where all of the infographics are stored, and you can select different languages depending on who you're working with. I did this one thinking of my wonderful mother, who is 86 in a month. And so she has diabetes, and so she thought that raisins were a really healthy thing because they're part of your 5 a day. So she kept them in a handbag all the time. She was never far away from a packet of raisins. But look at that. A small helping of raisins, 60 grams, that's a small helping, is the same as 10 teaspoons of sugar. That's why my mother ended up on metformin. That's why she had high blood sugar and was heavy. We lump fruit and veg like it's all the same. So first of all, I really advocate green veg. Green veg, green veg, green veg. Turn the white stuff on your plate green. Have loads more green veg because it doesn't put up your blood sugar. Fruit varies. And it varies depending on how long it spends in sunshine, because sunshine is photosynthesis. Photosynthesis is fixing carbon into glucose. So you've got 2 types of fruit. You've got tropical fruit like a mango or pineapple or orange sitting in the sunshine making loads of sugar. Or you've got the poor old Scottish raspberry sulking there in the mist. Hardly any sugar goes to the Scottish raspberry. So the berries are generally far less sugary than the tropical fruits. And if you juice the fruit, it's even worse. So that glass of fresh orange I used to have every morning got me off to an incredibly sugary start. Right, this is the diet sheet. I'm hoping each of you got a copy of it on the table in front of you, and I've got spare copies if you need any more. This is the A4 diet sheet we've been using at Norwood Avenue more or less from the very beginning. And so we don't need to go over it now, but basically it's base your meals on protein. What is the protein that you're going to eat for your meal? Is it fish? Is it eggs? Is it cheese? Is it red meat? What is it? Add loads of green veg and then a bit of fatty sauce to make it tasty. That's kind of low carb in a nutshell. If there's time, I could go on and on. There's recipe books, there's loads of stuff on low carb. It's a very low carb, or the keto diet, one of the top 2 popular diets now. Oh yeah, it is very important not to forget about medication. So if patients are on drugs for diabetes and then they go low carb, they may have 2 factors lowering their blood sugar. So hypoglycemia is a possibility. It's pretty obvious if you're on insulin and then you reduce drastically the amount of sugar, you could go hypoglycemic. So it's very important to know you can't just go low carb without discussing it with a healthcare professional. I'm going to show you a slide in a minute that encapsulates all of the different medications and what you need to do or don't need to do. The second thing is, this is really intriguing. At the beginning, I discovered that people who went low carb, including me, got muscle cramps if we didn't have loads of salt. So we're going to talk about that. You actually need more salt if you're on a low carb diet, and I'm going to help you understand that. But not yet. Oh, here we are. This is me. Freestyle Libre, they're all the rage, aren't they? I think they're good because they give you feedback, and feedback is part of behavior change. So I did this for Twitter. I have a lot of Twitter followers, and I said, what do you want low carb GP to eat? And they would write up with suggestions. So that is the top 2 lines of me on a low carb diet, and nothing happens to my blood sugar at all. So obviously during those days I wasn't fasting, I was eating stuff, but my blood sugar wouldn't shift hardly anything. Look at the 3rd line down. I ate that bowl of rice, and it doubled my blood glucose to 10.3, making the point that rice is sugar. And I don't feel very well with a blood sugar of 10.3. I can't concentrate quite as well. The Freestyle Libre I find so interesting. I'm using it more and more for patients with type 2 diabetes, which is slightly against the guidelines. But I don't care. I don't care because I'm saving money. So my CCG are very unlikely to lock me away because we're saving them so much money. And the Freestyle Libre, what I do with my patients is I say, I will prescribe just 1 month's worth of the thing you put in your arm, the sensor. It's a one-off, and you've got 1 month to learn. And I'm breaking the rules for you. Download the reader on your phone. So that's my way of giving them a month of the Freestyle Libre. They download the app on their phone and they find out where the sugar comes from. One guy was on insulin only because he ate so many cornflakes. I didn't know till I said, what's that spike? Went up to 17. And he showed me he was eating cornflakes in a mixing bowl. Okay, so he said, I can't use an ordinary bowl. Nobody, he said. Nobody eats cornflakes like that. So the only reason he needed insulin was because we'd never dealt with the source of sugar. And he's been off all drugs for diabetes now for 2 years. He's never slipped back. So grateful, and it didn't take me long. That was worth the Freestyle Libre. Okay, this slide, you probably can't even see it. So what this is a paper that's freely available on the British Journal of General Practice. And it's a summary of all the drugs for type 2 diabetes and how you would deal with low carb. The good news is metformin, the commonest used drug, is perfectly safe with low carb. So whether you're on metformin or not and you go low carb makes no difference, but other drugs do make a difference. Again, if you want to see that, you could take a screenshot of it, or you could Google BJGP and Unwin drugs for diabetes. And it's the British Journal of General Practice, published about 3 years ago, with a very useful summary. But if they're on metformin, it's fine. Glycoside, I tend to half. Glycoside makes you fat anyway. Insulin is quite a sophisticated thing, but I'm reducing doses of insulin all the time. Of course, they're insulin resistant, so you'd be surprised. You can drop the insulin and not much happens. Oh, here's a great thing. Patient said to me recently, a lady, she weighed 16 stone, and she said, Dr. Unwin, I weigh 16 stone. I'm a big woman, as you can see. Why am I hungry all the time? Because I'm full of food. Why am I always hungry? And the truth is, I was always hungry every day of my life till I was 55 years old. No matter how I snacked, no matter what I ate, I was the kind of dad who's watching your children to see if they've finished that ice cream. You know, my son Edward was slowing. Oh, good, I'm going to get that. Have you finished? Have you finished? Just give me that. Or, you know, if you're scraping the plates, maybe some of you do this, and the pudding or whatever, I would have eaten it. I was always, always hungry. And yet today I stand before you, I've run this morning, I haven't had lunch, I am not hungry. And you heard Roy, he's not hungry. Isn't that weird? So why are people so hungry? Because we need to think about why people are hungry, because that's why they overeat. They're not, when they tell you they're hungry, they're not lying. They're genuinely hungry. Right, this is why. So insulin is so clever, isn't it? So it has an imperative to get rid of sugar. So if you eat biscuits through the day, as I did, it's got to get rid of that sugar. So the last thing it wants is you burning fat as fuel, because then you wouldn't burn as much of the sugar. So insulin prevents fat burning. So if you snack a little bit all day long, you will be hungry, because your insulin is preventing you from accessing your own fat reserves. When you go low carb, the patients tell me by their 100, they can't believe that they're not hungry. It's just unbelievable. And that's because they're burning fat. The greatest losers, I've got 2 patients who've lost 11 stone of fat. 11 stone. One of them was so heavy we couldn't weigh him on any machinery that we had. He was somewhere over 160 kilos. The way we did it, I couldn't measure his waist either, because the tape measures weren't big enough. His waist was somewhere over 1.5 meters. Only 28 years old. Came to me for bariatric surgery. Bariatric surgery is great, but a few people die. I've had patients die of electrolyte imbalance. He's 28 with a daughter. Come on, we need to try something else. Anyway, also he had sleep apnea. And I said, are you up for something else? Because I've got an idea. And that, honestly, what joy that boy has given me, transformed 11 stone. And his goal was to be a better dad. He had a daughter, and he felt so lethargic, and he said, I'm a rubbish dad. I'm just too tired. And so he has burnt. He's in ketosis. So he has now burnt all his fat. He must have done. It's gone somewhere, and he's not hungry. So this thing about insulin, we are a dual fuel engine. You can burn glucose or you can burn fat. If you have diabetes, burning glucose is difficult because your insulin's not working properly, but you can burn fat completely normally. The other thing is, did you know, so we do need a little bit of glucose for a few cells in the body, but nature's always there before you, and you can make enough glucose to live, gluconeogenesis, from fat and from amino acids. So there is no nutritional amount of glucose that's necessary in your diet at all. So if you have type 2 diabetes, don't have it. So problems or worries. So obviously I've been going all over the place talking about this, and people have worries about the low carb approach, and they tend to have 2 types of worry. Here's the first one. Increasing dietary. So if you don't eat carbs, you eat something else because you're still eating. So you've only really two alternatives. They tend to increase dietary fat. So then the worry is, well, surely increasing dietary fat is going to ruin your lipid profiles. A reasonable statement, and until 2012 I thought that was probably true. You've already got a hint though, because the triglyceride doesn't come from eating dietary fat. The other thing is dietary cholesterol has no effect on serum cholesterol. So it doesn't actually matter how many eggs you eat or prawns. It doesn't make any difference to your serum cholesterol because it's in homeostasis, so your liver balances the amount of cholesterol. And the British Heart Foundation dropped all mention of cholesterol, dietary cholesterol, in 2006 because they acknowledged that dietary cholesterol makes no difference to serum cholesterol. And the other worry, some of you will have heard, remember the Atkins diet? I used to worry about the Atkins diet, but I had to admit the patient lost weight. And I think my worry was vitamin deficiency, but also I'd read somewhere that high protein diets kind of ruin your kidneys. And so there's another thought, that does the extra protein that people eat, is that going to ruin their kidneys? So I've written, I think I've got kind of a team, so I've got a medical statistician. I teamed up with a professor of nephrology, a professor of cardiology, and a professor of weight loss, and I've written about, I think it's 14 peer-reviewed papers now, looking at all of these things. And if it's rather a busy slide, but if we just go down through it. So the average weight loss at Norwood Avenue is 9.5 kilos. I've got data on about 340 patients, and the average weight loss is 9.5 kilos. The hemoglobin A1C improves on average by 21 millimoles per mole. That's a huge average. And if you look at how they start, so people think maybe I cherry pick easy cases. I do the opposite. I love the heart sinks. So if you look at the average hemoglobin A1C at the beginning, the baseline there, 65. That's my average start. The highest hemoglobin A1C I've dealt with was 144. That is sky high, sky high. So I'm not cherry picking easy cases. They're getting amazing results. The next three figures are what happens to kidney function at Norwood Avenue. So we've got the baseline, we've got where it ends up, and all of them improve significantly. The renal function gets better. Next up are the lipids, serum cholesterol, HDL cholesterol, and triglyceride. So the serum cholesterol improves, the HDL, you remember that's the protective cholesterol, that goes up. That's good news, so the ratio is much better. The triglyceride drops by about a third. And then the blood pressure, we're going to come on to that. Bit of a mystery there. The blood pressure improves so much. How interesting. And yet they need more salt. That's really interesting too. So these people are having more salt and the blood pressure's going down. I wonder why that is. This is one of the papers. I put it up because in the paper I've tried to chuck everything into it that might be useful to clinicians. So in the supplementary file is the low-carb Norwood Avenue nurse protocol and the diet sheet and the psychological profiles. So if you Google, I think this one is Google BMJ, Unwin and low carb, this will probably be the top thing there. So that's a paper published about a year ago, and it's in the top. So there have been 16 million papers written, and that paper, because it is of such great interest to people around the world, it's in the top 0.3% of all papers ever written. So, you know, as clinicians, that shows we have interesting stuff that the academics can learn from, because that paper is up there, it's the second most read paper that journal has ever published, because the low-carb world is very lively. So in that paper, What's interesting is we got 93% remission of prediabetes, so I started thinking about the pre-diabetics. 93% of them I can sort out. They never get to be diabetic. That's great. One of the things I love most is that older people do so well. The older people do just as well as the young ones. And because I'm 63, dear to my heart, older people can do stuff. They lose weight, they do well. And actually, they did slightly better than the young ones. Also, the people with the worst blood sugar got the best results. The people who you would tend to prescribe drugs for do the best, and that's because their diet is so sugary. It's so sugary that when you start reducing, that's why they have a high hemoglobin A1C, because hemoglobin A1C is a reflection of how sugary you have been in the preceding 3 months. So if you eat loads of puddings and biscuits and crisps, you're very sugary. So it's no surprise that when you cut that, it improves. So a high hemoglobin A1C doesn't always mean panic, prescribe. It means do something about the cause of the high hemoglobin A1C and monitor them. One of the things, there are 1 or 2 traps that I would share with clinicians. If you get somebody who goes low carb and loses weight, but the hemoglobin A1C goes up, something sinister could be going on. And I'm wondering now, I've spoken for so long, anybody from the audience got an idea somebody's weight goes down, the hemoglobin A1C goes up, and you should be worried. What's wrong with them? Yes, shout it. Well done. It could be pancreatic cancer. I've only ever found one in 10 years, but I'm glad I found that one. The other thing is they could be a misdiagnosed type 1. Some people, they get diagnosed as type 2, but they're actually type 1. And of course, they need insulin. So they're losing glucose in the urine, they lose weight. So if you get somebody who goes low carb, they lose weight, and the hemoglobin A1C is climbing, consider either a hidden malignancy, possibly pancreas, or they were type 1 and you've got it wrong. I think I've only found one misdiagnosed type 1, but to that person, they were very ill. It was so important. So that's just the pre-diabetes. So we get 93% of people sorted with, they're the easiest. Because of course the metabolic illness isn't as bad when you're pre-diabetic. So I'd hardly fail with any of them. They do really well. This is looking at, that's a pie chart, and of all the people that choose low carb at Norwood Avenue, which is 1/5 of the whole of the diabetic register now. No, it's more than that. It's 143 divided by 500. I can't do the sum. Let's say it's 30%. I don't know. Anyway, of all the people who choose low carb, 97% of them get improved blood sugar. 97%. That's quite an effective treatment if 97% of people aged 61 with an average weight of 100 kilos, that's what they weigh. On average, my patients weigh 100 kilos. And 97% of them get an improved blood sugar. I only get worse diabetic control in 3% of the people I'm working on. That's astonishing in general practice. Oh, this is the renal function paper. This was only published a month ago with Professor Wong, Professor of Nephrology from Liverpool University. That's a bit wordy, isn't it? Anyway, the renal function improved, to my amazement. And in fact, I'd missed this. It was my wife who said, I was doing public speaking in Ireland, and somebody stood up and said, why aren't you worried about the renal function of your patients? Because all that protein is surely destroying their kidneys. And I was dead scared, because I thought, well, maybe it is, but I haven't noticed any. And so I thought, why don't I audit? It's very easy to do. I know who the patients are. We audited kidney function, a baseline, and then afterwards. And I'd missed the fact that across the board, the kidney function was improving. This is a particular case. So this is eGFR. Up is good, down is bad. So this person Their kidney function was so bad back in 2016, they couldn't actually use metformin. You know, you can't use metformin for somebody with poor renal function. So they put him on insulin, and glycoside, and doxazosine. So they medicated the hell out of him. But then he came to see me and we went low carb. And I got him off insulin, glycoside, doxazosine. His blood pressure is normal. He's off insulin. But look at his renal function. It's normal now. So he's gone low carb. It's only one example. But the point is, if we look at all of the patients, who go low carb at Norwood Avenue, you would expect over 2.5 years their kidney function should deteriorate because they're getting older. The first thing, older kidneys aren't as good. And having diabetes causes your renal function to deteriorate. So looking at the cohort going low carb, they should have worse renal function at the end of 2.5 years. And it should have deteriorated on average by 2.41 mils per min per 1.73 meters squared. But it did the opposite, improved. So it should have gone down, it should have deteriorated by about 2.5, but it improved by about 2.5. It did exactly the opposite of what I was told to expect. So renal function does not seem to be a worry for most people going low carb. Hooray, for me particularly, because I was worried and now I'm not. Now we come, this is the mystery bit, like a whodunit. So I've seeded through the talk 1 or 2 questions. And the questions were, isn't it funny that people who go low carb need more salt? And isn't it funny that they have more salt and their blood pressure improves? Some of you can probably guess what's in that jug. I bet you can. And I'm sorry to tell you, it's one of my wife's jugs. And what's in it is urine. Oh dear. And that's to remind me that people who go low carb get a marked diuresis. They wee lots. I wonder why. What is going on? In fact, they wee so much that I'll often cure swollen ankles. I've had several cases of terminal heart failure. One of them was a guy of 84 and his wife said, please can we do something because he's wetting himself with all the water tablets. I know he's dying, but do we have to use the water tablets because that is, I can't stand, he's such a proud man, I can't stand to see him. Well, we put him low carb, he weed loads, and then his wife came back, she said, well, he's just cleaned the car and he's about to do the garden. And he's still alive now. So there's something weird about going low carb and you wee loads. So that's 3 weird things that I noticed back in 2013. People who go low carb wee pints and pints of fluid. And they need more salt. And their blood pressure improves significantly. So much so that I was forced to deprescribe over 20% of all the drugs that they were on for blood pressure because they felt faint when they stood up. I felt faint when I stood up. I used to have moderately raised blood pressure. Now I have normal blood pressure. So I was actively stopping drugs for diabetes. So why is all of this? What is the link between insulin, salt, and blood pressure? There is a link. Here's the surprise. So I spent years looking into this because I was so fascinated. I thought, surely we know why people who go low carb have better blood pressure, need to have salt, and we have known since 1933 that insulin causes your kidneys to hoard salt. So if you have a high carb diet, you can't wee out the salt. And then when you go low carb, you weigh out fluid and the salt. God did not design us to die if we had too much salt because you live by the sea. We've got homeostasis. We should be able to wee that salt out. But if you have carbs, you can't wee the salt out, particularly people with diabetes. And we have known this since 1933, which is kind of a scandal and a worry. So they did an experiment in 1975. They gave insulin infusions to humans, and they discovered they stopped weeing out their salt. Well, that's what I just said. In 1997, another report was talking about the explanation for the clustering of insulin resistance and high blood pressure. Because if you're insulin resistant, your kidneys are hoarding salt, you're on a high carb diet, the salt is putting up your blood pressure. But to blame the salt isn't quite right. It's not quite the villain. Maybe it's a different white crystal. Maybe it's the sugar. In 2018, another report here. Our analysis suggests that insulin plays a primary role in hypertension, highlighting the tight link between essential hypertension and diseases associated with a metabolic syndrome. I remember I went into the doctor's common room and I was saying, I wonder what the cause of essential hypertension is. And they said, for heaven's sake, David, that's why we call it essential hypertension, because nobody knows what the cause is. How likely is it that we don't know the cause for one of the commonest killers in the world? We do know, and we have known since 1933. What's interesting is that none of us have read about it, but it's all there if you search. And here's the final paper. Finally, I've written, a lower glycemic diet may lead to important reductions in blood pressure. So, insulin causes you to hoard salt at the kidney. You go low carb, you weigh out the salt, you weigh out the fluid, your blood pressure improves, but to the extent that you might need extra salt, as I do. If any of you are interested in fasting, which is a different subject altogether, you definitely have to have extra salt if you do intermittent fasting. I'm going to accelerate a bit. This is about salt, because I want to give time for you to all ask questions. I'm often asked if remission of diabetes is sustainable over time. Does it last? Is it worth all the effort? And the answer is, it depends. It depends. This is Chris, another before and after. This is his hemoglobin A1C over about the last 15 years. And you can see here, that's where I first had a go at him, and he went into remission. And then what happened here? Look how his hemoglobin A1C is rising. A lot of clinicians at this point say, oh, the diet's failed, here's your metformin and your glycoside and all the rest of it. The diet hasn't failed. He's not on it. Carb creep. It's Christmas, it's a birthday, it's a holiday, and people go back to the carbs because they're addictive. What he needs is, Chris, where do you think the sugar has come from in your diet? Because that hemoglobin A1C looks as if you're very sugary. And he goes, oh God, it's biscuits and red wine. You know, and then look what he did. He improved it, and he's done better ever since. And oh, he's the same age as me, and he looks like that. And he used to look like that. So maintenance is key. The way in primary care, looking after our patients long term is absolutely key to what happens to them. And if we let go, we live in an obesogenic society, and everybody offers you biscuits, like you've all got those biscuits in front of you right there on the table. And everywhere you go, it's a birthday, it's a celebration, you know, it's a bottle of Prosecco, and I've got Doritos, and, you know, endless avalanche of carbohydrates. And we need to help our patients because to Chris it really matters, because he wants to be well. So the final thing to consider is, in primary care, how each of us would support our patients. And if we look now, this is the data from Norwood Avenue. This is the remission rate we're getting for those who choose the low-carb approach, and that's the remission rate for the entire practice. And if we just cut to the entire practice, so in 2017, we got remission of 4% of the entire diabetic register. I've now got remission of 21% of the entire diabetic register at Norwood Avenue. And it's because we are endlessly interested in maintenance and support and running groups. How are you going to look after people in a way that you can afford? And in fact, for years, we ran groups in the waiting room. We now do Zoom groups. And I know, again, the Public Health Collaboration have ambassadors that cover the whole country, and for free, they will help you in your practices run low-carb groups. So you can have somebody, we've got a PHC ambassador in our own practice who helps us run the low-carb groups, which are on Zoom, because it's the only way we can do it in the NHS and not spend too much money. So you really need to think about how to support people long-term. This is, I think, my final slide, hooray. And something really important happened about a month ago. And what happened was the BDA, which is the British Dietetics Association, the British Dietetics Association actually invited a review of low carb, and so they got 5 senior clinicians who do low carb and 5 senior dietitians within the BDA, and these are the conclusions, and this was published a few weeks ago. So this is actually in the BDA's own journal. So, type 2 diabetes remission should be considered as a treatment goal for people living with type 2 diabetes. It should be a treatment goal for all of us to discuss with patients. Are they interested? How might they do it? Total dietary replacements, are talking about the shakes, and low-carb diets have been demonstrated as being effective in facilitating weight loss and remission. The dietary approach should be one which the individual can maintain long-term. One of the great things about low-carb is you don't have to calorie count or weigh any food. Nowhere in the diet sheet does it say how much bacon you can eat or the weight of anything, because I think normal life is not about weighing scales in the kitchen. It's just about eating normal food and getting on with it. So one of the advantages of low carb, it's sustainable because it's a way of life. You don't have to weigh stuff. You're not on a diet, it's a lifestyle. Based on evidence from clinical trials, maintenance of weight loss appears to be the main driver of continued remission. So one of the things about maintenance, I weigh people a lot. I weigh people far more than I take blood pressure. I think it's more important. I weigh people a lot because they know then how they're doing. Total dietary replacement and low carbohydrate diets, if supported, are considered safe and should not be avoided in suitable individuals. So we have agreement there from the British Dietetics Association, senior dietitians and clinicians, that we should be thinking about this, and it does work. Low carb diets, people say it's a kind of fad diet, don't they? So I'm on a fad diet, apparently. Well, that's the kind of food I'm eating there, and I would say that just looks like healthy food. If you don't like the idea of a low carb diet, you could talk about green veg, unprocessed meat, eggs, dairy, nuts, seeds, fish, berries, whole foods, and dairy, cream, stuff like that. So it's not a weird diet, it's a lovely diet. I love the food I eat. This is a cookbook that I helped write, and the only reason I agreed to write it is a proportion of the profits go to the PHC. As I said, nobody pays me to do anything, so my wife and I got together with an Italian chef who'd reversed his diabetes and wrote a recipe book, because people think, well, what shall I eat? The Royal College of General Practitioners, I published an e-learning module. It takes about half an hour. It's published by the Royal College of General Practitioners. I think it's the most popular e-learning module they've done. 2,500 GPs have done it so far. It takes half an hour, and it's on the Royal College of General Practitioners website. Final thing, I think this is the last slide. So, pardon? All you have to do, the question is, can nurses do the RCGP e-learning module? All you have to do is access it through the GP in your practice, because they've got free access to it. You can. Good point. You can also register as a nurse and access it for practice nurses. So I see, good diabetic control is important because we learned at the very beginning that people with poor diabetic control are losing 100 days of life for every year they live with that poor control, and they die of cardiovascular disease. The model I have of diabetic control is dead simple. It's sugar in and sugar out. It's like a sum, isn't it? How much has gone in and how much is coming out, and the sum adds up to how much is left in the barrel. So if you eat more sugar, there's more in there, but also sugar out is a help. So exercise gets rid of sugar. Some of the insulin gets rid of sugar by making you fatter. Insulin is fat fertilizer. You know, if you put type 2 diabetics on insulin, they'll gain about a stone in weight easily. The new SGLT2 inhibitor drugs cause you to wee out sugar. So that's another way to solve the problem. Why don't you wee out the sugar you shouldn't have ever eaten in the first place? Just a thought. So that's my point, really. Why don't we turn off the tap? Rather than just pouring loads of sugar in and trying to bail out the barrel, trying to cause you to wee out the sugar, we should be honest with patients about you could turn off the tap, and they are interested. Finally, the last patient. Oh, I love this guy. Right, he is 83 years old, and I am holding the tape measure where his belly was when he first came to meet me. And his worry was that he was so fat he couldn't walk straight. He had a terrible waddling gait. Also, he's on insulin, so his blood sugar control was brittle, and he was worried about driving a car. So his worry was independence and driving a car. He's gone low carb. He's been off insulin for 2 years. Recently, he was late for an appointment, and guess why? He was doing weights in the gym. He's 83, and he said, I got carried away, I was doing weights. I'm so proud of that guy, but he is proud, and really he's not a patient, he's activated and interested. And he's done a video for me as well for older people, because he wants doctors to know the difference that that approach has made. So there we are. For most patients, the cause of type 2 diabetes is dietary. It's what we've eaten our way into this epidemic. My patients' genes haven't changed since 1986. It's not a genetic disease. They're the same people. It's one generation. There's 8 times more of them now. So something environmental, it's not genetic. You have a genetic predisposition, but our environment, the food environment, has activated what was there all along. Type 2 diabetes, drug-free remission can be achieved in different ways. I'm not saying there's only one way to do it, but it's certainly a realistic goal for our patients. Finally, a low-carb approach can also improve weight, blood pressure, lipid profiles, renal function, and most importantly, self-esteem. Self-esteem, so precious for our patients. Many of them have given up. The heart sinks have given up because we moan and moan, we add the drugs, they think there is no future. They don't think. They just expect to die. If you ask them, they say, well, to be realistic, Dr. Unwin, I expect I'll die. Because they've seen people now. They've all been to funerals. They've seen what happens. So to give them self-esteem and hope. But the other thing is, I think as clinicians, for us to have hope and enjoy our jobs. All the GPs I know, they're so exhausted. The nurses are fed up. They've not enough appointments. We're all getting, we're rubbish apparently. So depressing. But if you could see a few patients like Roy, what a difference that would make. And that's just brilliant medicine. I think that's enough, don't you? Thank you very much. I've finished now. So I'm anticipating questions because they usually are. So I'm going to leave silence in a minute. And there's a mic, so I want everybody to hear the question so that otherwise my answers would make no sense. Hello.
Hello, thank you very much. Really enjoyed that. Really good. What about alcohol, though?
Great point. I love a drink as well. What about alcohol? Great question. There is a spectrum of sugariness to alcohol. So on one side, over here, you have very sugary things. Baileys. My wife used to love Baileys. That's very sugary. Drambuie was another thing she liked. Beer. I used to like beer. My son calls beer liquid toast, which is why you get the beer belly. So over here are the very sugary things. And then as I move across, less sugary. So over here, we're about dry white wine or red wine. So if I drink, I probably would have a glass of red wine. A little bit further over here, this is the good news, champagne. So you can have a celebratory glass of champagne. Costs a lot, but I don't drink as much anymore. And then over here, even lower sugar, is that glass of whiskey I might occasionally have, or a brandy. Or I would have gin with ice cubes and some slices of lemon. So just like the fruit, there is a spectrum of how sugary alcohol is. There's a very useful website called Diet Doctor. This is run by a Swedish GP, Diet Doctor, and that's got some useful stuff about alcohol and how sugary it is. Alcohol generally for somebody with type 2 diabetes, because of the effect on the liver, I would avoid it slightly. But come on, we all go to parties, and so yes, I do drink, yeah. Can we have the mic?
Hi, it's just a question about when you're de-prescribing, at what point do you stop metformin?
Great. So when do I stop metformin? So the first thing for me is, has the patient engaged with what's going on? Because I want them to be safe. So I don't want to take the metformin away when I don't know whether they're really low carb. So I always wait, probably about a month. Are they losing weight? If they're losing weight significantly, they're almost certainly low carb. And the second question is, what is their attitude to the medication they're on? So would they rather leave it a bit? Or some people are so keen because perhaps, I think it's 20% of people on metformin get either IBS or loose motion. So some of them are very keen to get off the metformin. Or maybe I might reduce the dose. Quite a lot of the people with hemoglobin A1C of the average 65 are on a high dose of metformin, so I would tend to halve it first. Glycoside, because of the risk of hypoglycemia, I usually halve that at the very beginning, but I monitor them, are they losing weight? Thank you, good question. Next one.
Thank you. How do you go about converting someone's mentality if they've previously been on something like Slimming World, which is offered on the NHS for a few sessions, to then low carb, which is actually can be quite the opposite of the Slimming World mentality?
Yes, it can. I think the first thing is I'm thoroughly interested in their goals. So before I do anything, I want to know what difference would weight loss make to you, and then I want to know how did Slimming World go. Because actually, if they've lost 10% of their body weight on Slimming World, you probably achieve remission. But the truth is, they've been to Slimming World a few times. They have, and they've done the Rosemary Colony, and they've done the, professional dieters, they've up and down, up and down. So I wouldn't knock anything that works. Why would I do that? But if their goal is better health and it isn't working, I need to go into that. And also, if you understand that you have diabetes because the sugar makes it worse, allowing cheat days and all the rest of it doesn't make any sense anymore. So that, even Roy wouldn't go to Slimming World after he'd spent the 10 minutes talking about why he was diabetic. So it's trying to, first of all, is what you're doing working? Yes or no? Presumably no. Secondly, what are your goals? And then the understanding of physiology and what bread does. So that's what I normally do, and it often comes up. It often comes back because there's a very strong local group. But the reason they make money is because people go up and down, bouncing weight over years. The only way they're least for a few weeks very often, and then they go on the diet before they go on holiday, or our so-and-so's having a wedding is very common, but it doesn't last. What I want is something that lasts. Hello, there's somebody over there, and then a lady there. Run, right at the back. Oh, the lady first then, because I've not forgotten you. Yes.
Hi.
Hello.
I was just going to ask, is there any plans to get your low-carb leaflet on our Accurix so we can easily text it to the patients? Because I'm not very tech-minded, and it's quite long-winded to download your leaflet and save it. And apart from sometimes the dietitians don't like the fact that I'm promoting butter either.
I don't know the answer to that. I've been working with EMIS. Did you have a suggestion there?
You can copy links from websites and paste it into Accurix, so then the patient can then go direct to the website and look at all the resources.
Oh, you've just answered the question. I wish you were on stage. Fantastic. So you see, you can copy the link. There we go. Yeah. And remember, all of these things are available on the PHC website, or you can photocopy the things there. What we did, we got a printer, and the cost of thousands of them was so small at a printer's that we just printed them off. The gentleman at the back was actually next, and then there's a lady at the front here.
Yeah, thank you for all that. What do you personally eat in a typical day?
Right. That's a great question. Increasingly, every meal you have gives a spike of insulin and makes you a bit hungry. So I now usually only eat once or twice a day. So I'll give you a few things. So I tend to eat, I'd have quite a lot of meat with loads of green veg. So yesterday I had a pack of lamb mince with a load of green beans and courgette. So I fried the mince with herbs and spices, like a mild curry and turmeric, and then I microwaved the green veg and add it all in. And I'm dead lazy, and my wife was on a course, so I couldn't be bothered, so I ate it out of the frying pan. And then for breakfast, I'd probably have something. If I have breakfast, of my second meal, might be something like full-fat plain yogurt with raspberries or strawberries and a few flaked almonds, something like that. I have a lot of omelettes. I like giant salads. I don't like small plates of food because they annoy me, because I'm still the greedy person I was before. So I like a big plate of food, but I don't eat as often. Thank you. There's somebody at the front here.
Thank you very much.
You're welcome.
I really enjoyed it.
Good.
You say low carb. No carb, but low carb.
Thank you.
How low and
Yes.
how much you would say, can I not eat rice at all?
Yes.
It's like,
Great question.
For some minorities, they love their rice.
They do. So the question here is about what is low carb? How do we go? It's all about, if somebody has type 2 diabetes, I'm getting them to move along that sugar spectrum. And you have to see where they are at the beginning. So some of my patients, maybe they weigh 25 stone, they're eating a lot of carbs. So for them, any kind of progress, if I could get them down to, if they could eat a third of the rice, if they could eat fewer potatoes, but more protein and more fat, that would be progress. So that's why we are clinicians, because this isn't a leaflet. We're trying to gauge what do you normally eat. So the question is, where do you think the sugar in your diet has come from? And you need it to reduce. Then the next question is, they need feedback. How are they doing? So I leave it entirely up to the patients. I don't dictate, but I do weigh them. I get the baseline weight, waist circumference, and the hemoglobin A1C. I'm going to review that again in 6 weeks. And if they're doing well, I won't criticize. Good. If they haven't lost weight, or sometimes they've gained weight, if the hemoglobin A1C is climbing, we need to dig down and they need to cut back further. A really useful hint for people who aren't doing well is get them to photograph every single thing they eat for 3 days on their iPhone. It's so interesting. It is so interesting what people think is a moderation and a normal diet when you see it on the plate. I got one guy, And in order to fit the food on the plate, he had a giant dish, and then he bought Yorkshire puddings to put like a fence all the way around the edge. And that meant the plate had a higher edge and he could pile it. And he weighed over 25 stone, and he said he ate moderately and a lot of green veg. So, but the truth was on the phone there. So it is about, this is the tailoring, and the most important thing is that they understand the sugar is a poison, need to cut back on it. Where does the sugar in your diet come from? And then support them and give them feedback. Yes, yes. There is another very good question is what about brown rice? One of the sugar infographics on the PHC examines exactly that, and I've compared the teaspoon of sugar equivalent with brown rice and white rice. You're going to be disappointed, I can tell, but the truth is that brown rice is very sugary still. Oh, yeah, it's about the same. The PHC, I've got it there. But it's a very useful infographic, and I did it deliberately because so many of my patients said I eat wholemeal bread or I have brown pasta. Yes, but it's not actually, you see, brown bread isn't really low GI. It's certainly not low glycemic load. So we talk a lot of, and it again depends on the portion size. And some of these people are eating a loaf of bread a day. When you ask them, nobody weighs 25 stone without eating a lot of something. And I had one woman, and she cried, a woman I'd looked after for 20 years, when I was trying to find out. She was wondering about bariatric surgery, and she was very distressed about her weight. And I said, where do you think the sugar comes from? And she finally said, it's bread. I've never told you this. And she cried and cried. She said, I'm like a mad person. I hate myself. I'm eating so much bread. Some foods are quite addictive, and they're in a habit of eating a lot, and you need to help them as well. So if they can't moderate whatever it is, then that's the very food they need to give up. Good question. Hello, behind you.
I know you've mentioned that you help a lot of people in a 10-minute consult, and I just wondered how much time each patient averages, because is it more than one 10-minute appointment?
Right, thank you. So how much time am I giving these patients to get the results? What's interesting is, that's a very interesting question, and it varies a lot. So some people get it at the first appointment. I don't see them for 6 months, and they come back to shake my hand and say, I bet you don't recognize me, do you? That kind of thing. Others need quite specific help. So there isn't, I could give you an average, but it depends. It depends. Let's try and, so I think in the protocol, so if you download the BMJ nutrition paper, BMJ Nutrition Unwin, I've put the nurse protocol for the practice as to what kind of goes on with our nurses and doctors. But generally what happens is I see them, I establish the baseline, I weigh them, I'm talking about their goals, and they get the diet sheet that you have there. I see them again, depending on whether they're on drugs, maybe 2 to 4 weeks later, and that's for them to ask me questions and for me to weigh them. If they're losing weight, you hope, and if they're not losing weight, we're going to talk about why that is. And then on average, at that point, we're planning the next blood test because they need the feedback to know how they're doing. So that at the second appointment, I'm saying in about 2 months' time, I think we'll be ready for another hemoglobin A1C, triglyceride, liver function, because I want you to know how you're doing. I think you're doing well. So that's a sort of average type. But then again, so the ones on insulin, I'm seeing a lot more. It's yeah, as a clinician, you're deciding how at risk is the patient in front of me, and how much time do they deserve, how much time do they need, and it kind of it depends how they do. So that's a slightly complicated answer, but I think that's what we're all healthcare professionals. We're using our judgment as to what is needed for patients because they vary a lot. I think we're coming to the last question now. I think we should, because I've got to train. Who's going to ask the last question? Somebody, yes. Could we have the mic? Oh, we got 2 mics. It's coming, the mic's there.
What would you say to individuals who are worried about the association with red meat and cancer?
Wonderful question, yeah. Red meat and cancer, I've really looked into this a lot. And so the short answer, but you're going to get the long one as well, I have looked into this. The evidence is all epidemiological, all of it. And that means what they do is they question people, and they get typically they'll get a questionnaire twice a year on what do you eat, and then they follow them up and see who dies of cancer. The problem with that is all sorts of confounding things. For instance, wealthy people live longer. So if you don't correct for how wealthy the person is, then you might think that somebody that eats a lot of red meat is a rich person and they might live longer, but it maybe was nothing to do with the red meat. So that's the first thing. And then if we look at the cause, I'm fascinated by the cause of cancer. So I'm trustee of a hospice. Cancer fascinates me. Also, your relatives die of it, don't they? So the cause of cancer, I know that central obesity is linked with 8 of the commonest cancers. So central obesity is linked to breast cancer, colorectal cancer, prostate cancer, thyroid cancer, many of the modern cancers. And insulin is implicated in cancer. And I actually think red meat is a complete red herring. Processed red meat is a different thing. But I think red meat is completely fine compared to eating junk food and having diabetes. We know that diabetes itself is linked to cancer. So that would be the subject of a whole afternoon. But I advocate red meat. I have no problem with it at all. Compared to the alternatives, it's much better. Pardon? Yeah. So yes, a lot of my patients eat more protein, and some of that is red meat. Depends on what they enjoy. I want them to enjoy their diet. I want them to often enjoy traditional foods that were traditional for their where they came from. So Marcia is from Brazil. In Brazil, they eat a lot of steak. That's just Brazil. And so she's gone back to eating like her grandma. So thank you. That was a good final question. Thank you. It's time to go. Thank you.